Good morning, everybody. This is Dr. Sonia McGowan with Covenant Pediatric Wellness Center. Thanks for joining me for our monthly webinar. Today, we are going to be talking about PANS and PANDAS. So October 9th, next week, is PANS PANDAS Awareness Day. So this is perfect timing. So we're going to be talking about when the brain is on fire. So that's exactly what PANS and PANDAS is. At its core, it's an autoimmune neuroencephalitis brain on fire. The trick is finding the trigger. So let's talk about it. Okay. So for today, we are going to be covering what is PANS and PANDAS. You may also hear it called autoimmune encephalitis. So we'll talk about, all of that together. We'll talk about the symptoms. We will talk about the triggers and then the testing and intervention options as well. You know what? I should give you a little guidance here. If you have questions, please drop them in the sidebar. There is a Q&A section. So whatever questions you have, just drop them in there and I'll answer them as I can. I'm happy to answer questions, and I'll save some time at the end also for questions as well. Okay, so there are a lot of acronyms when it comes to PANS and PANDAS. So PANS stands for Pediatric Acute Onset Neuropsychiatric Syndrome. PANDAS is the same, except it is associated with strep. And at its core, like I mentioned, it's autoimmune encephalitis. There's, it depends on who you talk to and who you read. There are people who say, basically PANS, PANDAS, and autoimmune encephalitis are the same. There are some who say that autoimmune encephalitis is kind of a step up. It's a little bit more significant or serious. You will also potentially hear it called CPIE, which stands for Childhood Post-Infectious Encephalitis. And you may also hear it called PIT-AND, Pediatric Infection-Triggered Acute Neuropsychiatric Disorder. But in our vernacular, the most common things you're going to hear would be PANS or PANDAS. All right, so let's think about this for a minute. So you may not need to imagine, if you're a parent on the webinar today, you may have lived this, but imagine that you have an 18-year-old child, neurotypical, had an onset of pretty significant symptoms 7 years ago after her sister was ill. So unable to leave the house, an extreme fear of vomiting. You will also hear that called emetophobia. Depression, suicidal ideation, and aggression. So she's fine until she's not fine. Also, imagine you have a 10-year-old neurotypical daughter with an acute onset of symptoms after a dental procedure. So she started having episodes at night where she would stutter and stiffen her body and have hallucinations. She had an acute onset of a fear of glass. So glasses that you drink from, glasses in the window. She had seizures. She had what her family called fear attacks. She would say things like, I can't do this anymore. My body hurts. They took her to the ER, and the people there said to just ignore and redirect her behavior. She also had a fear of choking and a fear of vomiting. And she also had pretty significant sensory amplification. So, being very sensitive to what she hears, to the things she touches, to the things she tastes. So these are kids whose parents will say, my child was fine until. Generally, they'll say things like they had a cold, they had a flare of their seasonal allergies, they had a tooth fall out, they had sedation, and then suddenly they have all of these acute onset new behaviors. So let's talk about how it fits together. So look at it, basically look at PANS as your overall umbrella. So under PANS, we can have infectious triggers and we can have non-infectious triggers. So if we stick with the infectious triggers, if the trigger is strep, we call it PANDAS. If the trigger is something else, so maybe a different bacteria, maybe a virus, then we call it PANS. If we move down to the non-infectious triggers, we call that PANS as well. And so those triggers can be things that are environmental or things that are metabolic. So let's say mold exposure is definitely a trigger for PANS. Things like anesthesia, sedation can also be major triggers for PANS as well. So in terms of diagnostic criteria, you have to be careful because some practitioners get a very limited view. Okay, so they look at the diagnostic criteria, and if the child's symptoms don't match closely enough, for example, if the onset is not abrupt enough or acute enough or dramatic enough, even if they have every other symptom, they're often told no, they don't qualify for this diagnosis. So if you're a practitioner, I'm just encouraging you to, zoom out and see the big picture and not to get caught up in the tiny details. But let's talk about the criteria. So it's an abrupt, acute, dramatic onset of obsessive thoughts, compulsive behaviors, or severely restricted food intake. So remember, our two case studies that we talked about in the beginning both had issues around fear of vomiting. So sometimes kids will restrict what they eat because it's a texture, a sensory thing. Sometimes, though, more often it is they're afraid they might choke. They're afraid that their food is contaminated. They're afraid they might throw up. We also see a concurrent presence of additional neuropsych symptoms with a similarly severe and acute onset from two of these categories. So it could be anxiety, which would include separation anxiety from parents or other close family members. We see emotional lability and or depression. And so lability means up and down. So, highs and lows in terms of their emotions. We will see behavioral things. So a lot of times we'll see a regression in certain behaviors. They lose some developmental skills. We will, so another symptom would be motor or sensory abnormalities. So this could include, motor tics, vocal tics, what we call choreiform movement. So a certain type of uncontrollable movement. Sometimes kids will say, they have changes to their vision, like they'll see things in their field of vision that aren't really there. Like I've had several kids tell me it's like snow that they're seeing when, they know that is not the case. We also see somatic signs and symptoms. So somatic means your body. So it could be things like sleep disturbances. We'll see bedwetting, and really any change in urine habits is pathognomonic for PANS and PANDAS. So if they suddenly are wetting the bed, they're suddenly having a lot of urinary frequency or urgency, they need to be worked up for PANS, PANDAS. And of course, the symptoms are not better explained by something else. And for PANS, there's no age requirement. But for PANDAS, we put all that together, plus we add the presence of OCD and or tics. There is an age requirement. So the symptoms need to be evident between ages 3 and puberty. But I'll tell you, we've got to be careful with that, right? Even if it's caused by strep, if it's before 3 or after puberty, technically it would be called PANS. But we have seen kids and adults outside of those age limits for sure. Acute onset and an episodic course. So you'll also hear that called relapsing and remitting course. So kids get better and then they have symptoms again, and then they get better and they have symptoms again. Of course, PANDAS is associated with a strep infection, and often we see neurological abnormalities. So we'll see changes in pupillary response. We'll see changes in deep tendon reflexes, things like that. All right, so let's talk about real life symptoms. So these are things that we see in the hundreds of kids who we work with PANS and PANDAS. So emotionally, we will see things like anxiety. And again, remember that includes separation anxiety. A lot of times the separation anxiety happens around bedtime. So these are kids who, previously slept alone, slept fine all night. And now they get great anxiety as the evening goes forward. When it's time to go to bed, they don't want to go to their room alone. They don't want to go on upstairs to their bedroom. They don't want to go to bed by themselves. They can't sleep alone. And anxiety can be, just the generalized anxiety, kind of a heightened, nervousness about everyday life. We'll see extreme mood shifts. Fears and phobias is a big one. So one of the cases that I talked about in the beginning was an acute onset fear of glass. So sometimes we see things like that, or we'll see, kids who are afraid that they're going to be poisoned, or they're suddenly afraid of germs. A couple of really common things that I hear in my patients is a fear of wind and a fear of water. So both of those things can be pretty common. So that can be a reason why a kid won't leave the house. Sometimes kids lose some of their hygiene skills because they have developed a fear of water. These kids often have a need to initiate or control interactions or schedules. And they will often talk about having deja vu, which is, of course, feeling like you've been here before. And sometimes we'll even have kids who will report something that we call jamais vu. So that is knowing that you are in a situation, you've been in this situation before, and you should know what to do, but you don't. And so both of those are pretty common. We also have behavioral symptoms. So again, extreme mood shifts. Sometimes we'll see rage episodes. Sometimes we see things like aggression or self-injury. Often these are kids who will lose hygiene skills. So they refuse to take a bath. They refuse to take a shower. Often refuse, to wash their face, wash their hands, their hair. We also see a loss of social and play skills. So, maybe we have a 12-year-old who has this acute onset of symptoms, and one of the things they do is, they're 12 and suddenly now they want to play with, toddler toys, for example, or they want to watch, immature cartoons. We also see a loss of academic skills. So suddenly they might look like they have ADHD, right? So they lose those, what we call executive functioning skills, the ability to plan and prioritize. They often struggle with a loss of handwriting and a loss of math. Those are kind of the two most common ones, but I'm seeing more and more kids who are struggling with a loss of reading skills as well. Sometimes these kids report that they have auditory or visual hallucinations. They can be very indecisive. So making decisions, it can be very difficult. They tend to avoid demands. They can't sleep alone, like I mentioned. Sometimes we'll see sensory symptoms as well. So the sensory amplification that we've talked about, a big one is misophonia. So they just can't tolerate hearing other people chew. Sometimes it's not just sort of a global thing. It tends to be directed at one person. I can't stand to eat dinner with my brother because I can't stand the way it sounds when he chews, for example. Again, kind of related to the phobias and fears that we talked about, the fear of wind and the fear of water are super common. And we'll see sensitivities to taste, smells, textures, sights, sounds, things like that. And then a lot of times we'll see that these kids have an increased need for sensory input. So they're constantly, seeking deep pressure. They're spinning, they're swinging, just trying to calm their systems. All right. Obsessions and compulsions are very common. So remember that obsessions are thoughts and compulsions are behaviors. So again, we have the anxiety, the extreme mood shifts. We see compulsive behavior. Sometimes kids will talk about having obsessive or intrusive thoughts, and rituals. Rituals around bedtime and rituals around mealtime tend to be, very common. So, parents will tell us he has to, touch the edges of his bed just a certain way and a certain number of times. All the stuffed animals have to be just so. The sheets have to be just right before he can settle down and go to sleep. We also have a lot of kids who will hoard. So often it's things like paper and cardboard. Sometimes it's other things. Sometimes it's food, sometimes it's any number of things. But hoarding is something that we very commonly see in these kids. We also have kids who will repeatedly apologize or confess. I'm sorry, I'm a terrible daughter. Why am I the worst sinner in the family? Things like that. And then a lot of checking behavior as well, making sure that everything is just the way it should be. And then we see some physical symptoms. So vocal tics, motor tics, the most common ones that we see in clinic are things like throat clearing, sniffing, snorting, things like that are very common. We also see like some kids will pinch the skin on their faces, or they'll, do certain movements with their mouths or their eyes. Sometimes it's a blink. Sometimes it's a shoulder shrug, gestures with their hands. So both of those, both motor and vocal tics are really common. We also see kids who generally their pupils are like dinner plates. They're just huge and they're not very reactive to light. And so that will often tell me that their bodies and their brains are definitely stuck in fight or flight. The other thing that we'll see is changes in deep tendon reflexes. So, when we check their reflexes on their arms, their knees, their feet, what we'll find is often either the upper body deep tendon reflexes are normal, but lower body are sluggish, or maybe they're brisk. Sometimes it's right to left. So sometimes everything on the right is normal, everything on the left is hyper or hypo. We've talked some about urine changes. So urine changes are a big sign, a major red flag. So if these are, kids who were previously potty trained, dry during the day, dry at night, and suddenly they start wetting the bed, they start having more urinary frequency, urinary urgency, this is something you certainly do not want to ignore. So definitely talk to your practitioner about looking at some of the labs that we're going to talk about. Kids will talk a lot about pain. So maybe they have headaches, they have a lot of joint and muscle pain. They often have repetitive fevers and often just sort of an ongoing low-grade fever. Losing teeth is a major trigger for especially pandas. So a lot of times parents will say, every time he loses his tooth, he regresses. His behavior gets worse. He starts having tics again. So sometimes it's a loss of a tooth. Sometimes it can happen again as that new tooth erupts. Sometimes even things like a cleaning at the dentist or placing of braces will cause kids to regress as well. Sometimes we'll see odd eye movements. We see sleep disturbances. So kids who will, they have night terrors. They start walking in their sleep. They start, talking and crying out in their sleep. All of that is a common symptoms that we see. And then a lot of symptoms around food and eating. So kids who will restrict their food intake for a variety of reasons, right? We've kind of touched on some of those. So they have a fear of contamination. They have a fear of being poisoned. They fear that the food might make them throw up. And many times we see a lot of rituals around eating. So they will only eat at a certain place, or they'll only eat during a certain time, or they'll only eat food that is white, or they'll only eat food that is green, right? And a lot of kids have a great deal of obsessive thoughts around, just being careful with their food, not wasting anything, not throwing anything away. And so that can, sometimes cause some issues around food restrictions. Okay, so remember, at its core, this is a situation where a child's brain is on fire. It's neuroinflammatory autoimmune encephalitis. Again, with multiple triggers. Maybe the trigger is infectious, like strep or Epstein-Barr virus. Maybe it's non-infectious, like mold or sedation. So any child who has a new onset of symptoms, or in kids who have a long list of diagnoses, they really need to be worked up for PANS and PANDAS. This is a neurological condition. It can look behavioral and it can look psychiatric, right? Many kids have atypical seizure activity. So we work closely with a couple of neurologists because we pretty regularly refer kids for an EEG because we just want to make sure that they're not having any sort of seizure activity. Okay. This is a very commonly misdiagnosis, sadly. So what literature tells us is that over half of all kids with PANS will be misdiagnosed and mistreated for over a year. Part of the reason for that is that about 65% of new strep infections did not give any symptoms. So the child has strep throat, but they don't have a fever, they don't have a rash, they don't have a bellyache, right? They don't have red tonsils, but yet that infection is immunologically significant. So it's it's also really common for parents to tell us when we say, "Hey, has your child ever had strep throat?" And they'll say no. And they're being honest. They literally have never had a strep diagnosis, but when we go in and look at the strep antibodies, they're through the roof. So what that means to me is they had a what we call a subclinical infection. So no symptoms that led parents to seek treatment for their child, but it was immunologically significant. So most kids are misdiagnosed with a variety of things. Often it's psychiatric because, to be fair, some of these symptoms really do look psychiatric. Often they get a tic disorder diagnosis, sometimes an OCD diagnosis. We hear behavioral disorders, things like um, um, pathological demand avoidance, reactive attachment disorder, oppositional defiant disorder. And, my favorite, which is completely ridiculous, is they will tell parents, if you would just parent him differently, he wouldn't act like this. Or if you would just spank him or put him in timeout or whatever, these behaviors would stop, which is, like I said, complete nonsense. Part of the reason that this is often missed too is that kids can often compensate or actively hide symptoms. They know that it would trouble their parents to know that they were having intrusive thoughts or that they were feeling like they, needed to engage in compulsive behavior. And so they actively hide it. Or they're able to sort of tamp it down. And so that makes us miss that acute onset window. So let's talk about triggers. There are many, many potential triggers. By far, the most common one, about 81%, according to the literature, is triggered by strep. So, what we see is that patients who have an OCD or a tic disorder diagnosis are more likely than controls to have had a prior strep infection in the prior 3 months. There's a higher risk among those who have had multiple strep infections over the last year. And the more strep infections a child has had, generally what we see are more frequent relapses. And again, many patients often have a history of a recent strep infection that does not present with sore throat, um, fever, all of the normal stereotypic signs of strep throat. And so what I will tell you is, if you have a child who has strep throat, do not hesitate to give antibiotics. That's not me talking as a chiropractor. It's me talking as a mom. That is one thing with my own kids that I would, if they had strep, we always did the antibiotics, because you don't want a simple strep infection to sort of morph into something severe like PANDAS. Other symptoms. Second most common is mycoplasma. So mycoplasma is the bacteria that gives us walking pneumonia. After strep, it is the next most common trigger. In my practice, probably the third most common trigger that I see is Epstein-Barr virus. So that's the virus that would give you mono. It would also give you chronic fatigue syndrome. It's exceedingly common even in young kids. We also see things like influenza and COVID causing this, Klebsiella, HHV6, cytomegalovirus. So lots of childhood viruses that we're all exposed to that our immune system should just handle and move on. Often the immune system gets stuck and just continues to upregulate against these bacteria and viruses and triggers the autoimmune brain on fire situation. We also see tick-borne pathogens as potential triggers. So Lyme and the different co-infections like Bartonella, Anaplasma, Ehrlichia, all of those things. Parasites can be a trigger, as can yeast. Mold toxins are huge. So one of our standard standing questions for all new patients coming in or existing patients who've had a recent onset of new behavior is, could there have been a mold exposure? And sometimes it's not always your house, right? That strikes fear in most people's hearts to know, oh my gosh, I might have mold in my house. But it may, it may be grandparents' house. It may be a therapy center. It may be their school or the library that they go to frequently. Kids who are complex are absolute sponges for anything negative, right? Whether it's a pathogen, whether it's some sort of environmental toxin like mold or metals or pesticides, herbicides, things like that. Which is the next one. Environmental toxins can be a trigger. So heavy metals, pesticides, herbicides, etc. And I mentioned this already, but anesthesia, any sort of sedation can trigger a regression, as can dental events. So losing a tooth, cutting a new tooth, things like that. Sinusitis and seasonal allergies tend not to be the initial trigger, but can definitely poke the bear in an existing PANS or PANDAS case. So the lab workup. One of the things that makes me crazy working with complex kids for all these years is parents know when something is off with their child, and they will often go to their doc and say, hey, something's not right. Can we run some labs? Let's just start with something basic. And most parents are denied this because a variety of reasons, right? I don't know what they are, but it's ridiculous. Starting with basic labs can really help us sort of hone in on what could be happening with this child. So I generally start with this first list, a CBC and a CMP. We always look at vitamin D. It is exceedingly common for kids to have very, very low vitamin D. The reference range on that is 30 to 100. In a perfect world, a kid would be around 75 or above. So if it's lower than that, you definitely want to supplement. We always look at a lipid panel also because low cholesterol can cause kids to look a bit psychiatric in some cases. It can definitely affect mood. It can definitely affect behavior. And I don't know about most, a lot of kids who we do this test on show pretty low levels of cholesterol. So we want to make sure that we're clearing out any other potential trigger, right? So if low cholesterol is causing some of this behavior, let's fix that and reassess and see how we're looking. Kids, well, all of us really should have a total cholesterol of at least 200. 225 is a little better. Our society really gets cholesterol wrong. We need cholesterol, especially kids, for good brain development, neurotransmitter, so many things, hormones. And so we always look at lipids. In fact, my webinar next month in November is talking about low cholesterol and how that impacts kids. So you definitely want to tune in. We also look at iron and TIBC. That stands for total iron binding capacity. And we also look at ferritin, which is the storage form of iron. We see very commonly that these are kids who have iron deficiencies. And in some cases pretty severe. And so we really like to see ferritin about 80, and it's common for us to see kids with a ferritin of 9 or 5 or 12, right? Sometimes we'll go a little deeper. We will look at a thyroid panel with thyroid antibodies. Sometimes we'll look at an anti-nuclear antibody to get a sense of autoimmunity. And sometimes we look at CRP as well to look at inflammatory markers. And then if we're suspicious of strep, and sometimes even if I'm not particularly suspicious of strep, I'll do this anyway. 2 different strep antibodies, ASO and DNase B antibodies. Sometimes we'll do a swab of the throat when they're in the office. Sometimes we'll do a throat culture or rectal culture. Sometimes we also do a comprehensive stool analysis. If we're kind of striking out on blood work, a lot of times strep will show in the gut instead of the blood. And cultures often will give a false negative. These are kids who, their immune systems are very dysregulated. So it's hard sometimes to get truly accurate labs on them. Sometimes what we'll also see too is we run the strep antibodies and they're normal. We do some intervention with maybe cholesterol or maybe nutrient deficiencies, mitochondrial dysfunction. We come back and test strep again, and then it'll be positive. So it seems that a lot of times these kids are almost too sick to show how sick they are on labs. Sounds counterintuitive, but we see it over and over. So we will also look at other antibodies as well. So mycoplasma, we'll look at virals, so all those viruses that we talked about. We will also very frequently, again, depending on the child's history and presentation, sometimes we'll do a sinus culture. And in that culture, we might find something called MARCONS, which is an acronym that basically indicates a certain type of staph bacteria that has colonized in the sinuses. Sometimes we'll find other things like strep or Klebsiella or E. coli or, maybe fungus that's colonized in the sinuses. And so that's a really important thing for a lot of kids because often many of their other labs will come back negative, but their sinus culture will come back positive. And that, I mean, if you think about where the sinuses are, right, in relation to the brain, it makes a lot of sense to just make sure that there's nothing happening in the sinuses. Often we'll do immunoglobulins. We want to look at IgG, IgM, IgA, et cetera, to kind of see how the immune system is functioning. And then, again, depending on the child, their presentation and history, sometimes we will look at an autoimmune panel. My very favorite is called the Neural Zoomer Plus from Vibrant America Labs. It comes as a blood draw or a blood spot, which is fantastic because blood draws can be hard for kids. But it will give us information about autoimmunity, different, brain antigens, things like that. The autoimmune brain panel was formerly called the Cunningham panel. It is the gold standard for insurance coverage, though, for PANS and PANDAS. And then often I will look at many autoimmune possibilities. So, maybe thyroid antibodies, other things like lupus or, different autoimmune situations. So sometimes certain kids hit the Yahtzee and they get multiple triggers. So maybe they have strep and mold. Maybe they have, strep and Epstein-Barr. PANS and PANDAS, both, right? So if all antibodies are negative, we don't find any infection, then we'll start looking at the non-infectious triggers. So things like mycotoxins or mold, heavy metals, chemical exposures. We'll, look around for any kind of anesthesia exposure as well. And then when it comes to intervention, we have to remember that I call it the first straw and the last straw. So often there are things that have made this child vulnerable for an infection like this. So, for example, the first straws that we often see are pretty significant deficiencies, things like low cholesterol, low iron, low vitamin D. We will see things like mitochondrial dysfunction. So kids who aren't great at turning their food into energy inside the cell, that is the cornerstone really of what we look for first. Because if they have deficiencies, if they have mitochondrial dysfunction, we're not going to get anywhere in terms of taking care of these infections or non-infectious triggers. So the first straw is often deficiencies, it's mitochondrial dysfunction, it's poor intestinal health, so malabsorption, maybe yeast or bacteria overgrowing in the intestine. This is what makes them vulnerable for the last straw, which is an infection that should be relatively, benign, short-lived, easily treatable without a lot of ongoing symptoms. But when your immune system is dysregulated, your system is weak, you're not making cellular energy, it leaves a child really vulnerable. So it's important that if you're a practitioner in this field, that you collaborate with other clinicians. So finding a neurologist, finding a counselor who can help the family, cope with all of this. Finding feeding therapists, for example. It's just important that there's a team around the child and their family. And this is not something that we just wait and see on. If there's an acute onset of behaviors that are troubling to the family, we jump in and we try to figure it out as fast as possible, because this is not something that most kids are just going to outgrow. And this is a situation that can escalate quickly. We don't want kids to get worse, so we don't wait and see ever. Some interventions are medications. So we work with pediatricians to sort of help them understand what's happening here, depending on what the trigger is, right? If it's bacterial trigger, antibiotics are the right way to go. Sometimes things like steroids are really helpful too, because this is such an inflammatory condition. It's really driven by inflammation. And so sometimes steroids can be helpful to kind of calm the system down. Of course, we here use natural approaches. So we use a lot of herbs, we use a lot of homeopathy. And improvement for a lot of kids can be pretty fast if we find all the right triggers, and we start with the right interventions, and we address what made them vulnerable to begin with. What's tough about the whole situation is tough, but when kids get better and then get worse and better and worse, that relapsing, remitting course is really hard on the child, and it's really hard on their parents, because just when you think, things are going well, I can exhale a little bit, kid's doing so much better, then suddenly something happens, they're exposed to something new, or, whatever. Maybe they have a mold exposure, they go to school and the kid next to them has strep and doesn't know it. Then it can cause a remission or a relapse. And it almost is like a PTSD situation for the family. So pretty hard to cope with. So if you're worried about your child, do not hesitate to reach out for help. We are always taking new patients. I have trained Dr. Lacey Mays to do this functional nutrition around complex kids and PANDAS. So we can definitely help you. And if we're not in your area, just search. You can go to the PANS Physician Network, pandaspPN.org. They have a physician directory. Also, there's a directory of MAPS physicians. So that stands for Medical Academy of Pediatrics and Special Needs. Their website is medmaps.org. They also maintain a directory of practitioners who are trained, and you can search by your zip code or your state. So definitely reach out for help. And if you feel like we're the right fit for you, definitely reach out to us as well. You can email me anytime if you're interested in making an appointment. The best way is to get with Brittany. She handles all my scheduling, and her email, I'm putting it in the chat, is brittany@covenantwellness.net. And she will be happy to help you. So that is a quick and dirty about PANS and PANDAS. I could literally talk for hours about this. We have a great deal of experience working with these kids. So if you're concerned and you feel like you need help, definitely reach out. Every month I do a webinar that is free. And if you have registered for it, you can watch the replay anytime. So our next one is Friday, November 7th. I think it should be a Friday. Friday, November 7th. And again, we're going to be talking about low cholesterol and how that can disrupt development in complex kids. So November 7th at 9 a.m. We also write and release 2 blogs per month. So in October, we have a blog coming out Monday and then again on the 20th. Both are specific to PANDAS. So one is, when it's titled When Words Won't Come, Understanding Sudden Onset Stuttering in PANS and PANDAS. And then the second one is about loss of academic skills in PANS and PANDAS. So that is a resource available for you. Also, if you go to our website, covenantwellness.net, every month we have a kind of a freebie for you that is just kind of a helpful resource. So this month, it is an infographic on the hidden symptoms of PANS and PANDAS. So it's talking about more of the subtle things that not so many people really understand or know about. That's free. You can download it, print it. It's on our website again, covenantwellness.net. Really nice resource. And then also, if you kind of explore our website a little bit, you will find the previous month's resources that we've offered as well. So, and then finally, I also maintain another website called thewhymatters.net. And let me put it in the comments for you. Thewhymatters.net. And this website hosts all of our previous webinars, all of our previous blogs. It also has some podcast episodes as well. So it's really a nice resource for parents who are looking for information around complex kids. So yeah, we just do our best to help as many families as we can who are, really struggling with these complex diagnoses. So, all right. So that's it. Any questions before I let you get on with the rest of your day? Happy to answer anything about, PANS, PANDAS, or something else. If you have a question about your child or about our practice, anything that we do, I'm happy to answer that. So, all right. Any last questions? Very good. Well, then I will see everyone next month. Oh, here we go. Sarah says, thank you so much. I'm overwhelmed and this helps me get started. Yes. And there are lots of really good books out there as well. There's Dr. Scott Antoine has a really nice book. In fact, I've got it right here. It's written for doctors, but he's just an excellent author. So it's called The Comprehensive Physician's Guide to the Management of PANS, PANDAS. So really, really good book. There are a few. If you have questions, you can go to Amazon and just type in PANS, PANDAS books, and a lot will come out for you. Do we accept insurance? So we have found that insurance tends to not pay for the things that we do. So we do, though, give you a super bill that has all the information you need to submit the charges for reimbursement to your insurance. Sometimes your insurance will pay for blood work. Sometimes they'll chip in on that. It really depends on your plan. We've got families who, their insurance pays for blood work all day long, very, very well. We have other patients, not so much. So we can work with you to kind of, help you figure out the best course for that. Lindsay says, have you ever worked with anyone who is already in psychosis from confirmed PANDAS? So yes, we have worked with some very, very involved cases. Once they have progressed to that point, the collaboration is really important because sometimes medications are needed to sort of help manage some of those symptoms until we can get the body a little bit more stable. But those super complex cases don't scare us. We're happy to work with those folks. And do you offer virtual visits on I'm thinking you're asking, do we have telehealth visits? We do both. So we have in-person office visits. We also have telehealth visits as well. All right, great questions. Any other questions I can answer for you? All right, so if you're wanting more information about an appointment, if you would like to schedule, again, Brittany at covenantwellness.net is your contact person. She'll be more than happy to help you. Our waiting list isn't terrible. So now that we have 2 docs who do this work instead of just me, our waiting list used to be long, but it's not so bad. We try to get people in as fast as we possibly can. So, all right, guys, thank you so much. I'm happy that you joined us today, and whatever we can do to help, just definitely reach out. My email is drsonia at covenantwellness.net. So you can always email me or Brittany at covenantwellness.net as well. All right. I hope everybody has a very fun, happy, good October weekend. And I will see you soon. Have a good day. Bye-bye.